Top Bed Talk.
This piece is divided into two parts, and this is part one.
This session is one that I am particularly excited for. It's entitled Preoperative Anticoagulation and Antiplatelet Management, a user-friendly approach. Dr. Jeanna Blitz, who is a colleague who works with me and has now really seen firsthand some of the real-life issues and problems and hurdles that we face every day among our colleagues in surgery and beyond about just simply being confused how to wade through this morass of literature and do the right thing. And to that, I thought this was an appropriate topic for us to have some discussion on. Before we begin, I'm going to ask everybody on our panel to introduce themselves. I'll begin with you, Jeanna.
Hi, from Durham, North Carolina. I'm Jeanna Blitz. I'm an associate professor of anesthesiology at Duke. I work with Saul, and I'm lucky to be there and have his mentorship. I am the director of our Perioperative Medicine Fellowship, and I am also the director of our Preoperative Anesthesia and Surgery Screening, our PASS clinic.
Hello, everyone. I'm BobbieJean Sweitzer. I seem to be the only person in Chicago, Illinois for this conference. I live here, actually, but I'm at Northwestern University. I'm a professor of anesthesiology. I have a background in both anesthesiology and internal medicine. I'm an associate chair for perioperative clinical practice at Northwestern. Saul and I used to work together at the University of Chicago, so it's a very small world. I'm delighted to be here.
I'm Angela Bader. I'm a professor of anesthesia at Harvard Medical School, and I am founding director of our Preoperative Center, as well as of the Society for Perioperative Assessment and Quality Improvement that both Jeanna and Bobbie are involved with. Currently, my major interests are in a research group at the Center for Surgery and Public Health, which is a combined venture from Harvard Medical School, Brigham and Women's Surgery Department, and Harvard School of Public Health. So very happy to be invited.
I think I'd like to sort of throw out there just a practical, real-life opportunity for us to speak to what a day in the life is like with respect to managing the anticoagulation questions that come up commonly. If you could all just sort of share an anecdote and how you managed to that throughout your years. And let's start with you, Angela.
Oh, sure. So I guess, I ran our preoperative clinic for probably about 20 years. And I'll tell you what I found, just practically some of the most common issues. One big one that I don't know if you guys run into is generic instructions coming out from the surgeon's offices that were incorrect. I used to, when everything was on paper, I would run around and collect them and try to, but they have non-clinical secretaries telling everybody, stop your blood thinners, stop your aspirin. And then we would be just chasing ourselves to try to stop that. So, it isn't even if the pre-op clinic has a good process. If people show up and they have already done something wrong because they have these generic instructions, and I would say it's less now, but we still have problems with that. So just to start off with an anecdote of how things can get in your way that have nothing to do with evidence or protocols.
Are you still managing it ad hoc, one at a time, with sticky notes posted on the side of charts, or have you begun to?
Right. We do have protocols, and the problem is that if the patient gets, what we started telling everyone is just don't change any medicines and let the clinic take care of it. And once they come to the clinic, then we use evidence-based protocols similar to what Jeanna had shown in her lecture. And that's sort of how we do the management. And now everything is in Epic. So we use Procedure Pass and Epic to ensure continuity, to make sure all of the appropriate instructions are followed through. So currently that's what we're doing. If they come to us and we are able to do it, it seems to work fine. The problem is when They come to us and it's too close to the surgery. And I would say, especially with COVID, we're seeing now people showing up 1 and 2 days before surgery. And because they're showing up 1 or 2 days, either they haven't stopped anything and have to get canceled, or they've stopped things that they shouldn't have. So I can tell you one of my worst stories was somebody who was 2 weeks after a drug-eluting stent, was in a rehab, and the rehab sent him over for an unrelated surgery, stopping dual antiplatelet therapy because that's what they do. So he went right from the pre-op clinic to a cardiology admission. But I mean, that's just one of the absolute, to be honest, the funny part of that story is I ran to the gift shop and bought aspirin because it was the quickest way I could get him an aspirin. And then the administrator joked and said, I'm going to have to write you up for giving a non-prescription pharmacy medication. But anyway, that was like one of the worst stories and a sort of black humor there. Anyway, he did end up having an MI, unfortunately, related to thrombosis. But that was an unfortunate case.
BobbieJean, this is a problem. How do you manage this in Northwestern's universe?
So I'm closer to yours and Angela's, sort of ages than Jeanna's. Initially, nobody was on aspirin, right? We stopped aspirin always. And we didn't have DOACs and NOACs, and we didn't even have maybe Lovenox. I don't remember. It's been so long ago, I can't remember. And so life was a little simpler. And everybody stopped aspirin. And then we went through this phase where, I think we really felt like there was benefits of continuing aspirin, particularly in higher risk patients. So it was like pulling teeth to try to get surgeons to continue aspirin, like trying to get rid of those standard guidelines and pieces of paper, right, that Angela mentioned. And, having some uniformity, some have evidence-based practices. So, and then, I think I did this at the University of Chicago, and I somehow got surgeons on board. I mean, just a quick anecdote. I remember we had one thoracic surgeon who was perfectly happy operating on low-dose aspirin. We had another one who claimed that all of his patients bled. And I tried all kinds of things, trying to give him evidence, trying to talk to him rationally. And I remember one day I said, well, that's interesting. It seems like Dr. X can operate just fine and his patients don't bleed to death. Is it possible that he's just a better surgeon than you are? And all of a sudden, he was perfectly happy continuing aspirin because he wanted to prove that he could do it too. So, I always say you use anything you can to try to get people to do the right thing. But then I want to say, lo and behold, poise came along. And I don't know if we're going to have a chance to talk about poise. But, I was very concerned because I think the devil's in the details with any kind of study. And I think poise tended to send this message, I think, to a lot of people who didn't know the background or the details that, we should be stopping aspirin, that aspirin, low-dose aspirin is associated with more bleeding than with more thrombosis. And frankly, I was very concerned that a bunch of surgeons would come up and say, see, we told you so. We told you so. We should be stopping this aspirin. And frankly, I have not seen that be the case. We actually have very, very few surgeons, only our surgeons that are doing intracranial, intraspinal surgeries that want us to stop low-dose aspirin. And they generally defer to our preoperative clinic because we feel very strongly that, we practice preoperative medicine. And we know more about the balance and the risk of bleeding versus thrombosis than our cardiologists and our primary care doctors. In fact, some of our surgeons had wanted us to stop the DOACs a little bit, earlier than what was initially felt to be safe. 24 hours, maybe only 48 hours but we know we have a fair amount of people who either start out with some renal insufficiency or develop perioperative renal insufficiency. So maybe they need a little more time to be off those drugs. We know that we do central neuraxial blocks, right? And maybe, ASRA guidelines didn't exactly, line up with what the PDFs or the practice, a guideline said about DOACs and NOACs. So we have very detailed guidelines. That said, I think we have 4 different anticoagulant guidelines because we do have to have them based on some service lines. Luckily, we managed to get all of our surgeons on board so that, it's not like surgeon X wants to stop it, so many days ahead of time and surgeon, Y wants to stop it a different time. So we got all the spinal surgeons to be on board with something, intracranial surgeons. We have our regional anesthesia guidelines and we have our routine guidelines. And then we have a total joint guide. But I would say that in clinic, we have APPs and physicians practicing, and we really hold their feet to the fire that they should follow the guidelines we have unless they have a really good rationale not to. And if they do deviate, they must get everybody on board ahead of time. So there's a lot of outreach and communication. We worked really hard with our hematologists and our primary care doctors and our cardiologists to make sure that they were in agreement, that they signed on to these guidelines, they felt comfortable with this. And I would say it's worked out actually surprisingly well. In fact, when I first went to Northwestern, I wanted to have bridging guidelines for especially patients with atrial fibrillation and valve replacements. And this is before the ACCHA had published their guidelines on at least atrial fibrillation bridging. I still don't think we have any guidelines really for their valves. And I asked, what their guidelines were, and they didn't have any guidelines. Even the anticoagulation clinic didn't have any guidelines. They just kind of did it on, like you said, Saul, on an individual basis. And there was quite a bit of variation. There was quite a bit of angst. There was all this kind of issues of people not knowing what to do, and people either showing up still on them or off of them when they shouldn't have been. It's not a perfect world. We still have some occasional patients that are falling through the cracks. But I think with a lot of education, a lot of outreach, a lot of, individual calling and trying to keep people on board, we've moved into a relatively, I think, safe space where patients usually consistently get the right, or at least best as we can tell based on evidence, what we think are the right guidelines. And if, for example, they're going to have a late appointment to clinic, then they reach out to us or they manage them because we have our guidelines open to actually everybody who practices at Northwestern. They're not just restricted to people who practice in the preoperative clinic.
Jeanna, it was the Wild West when you got here. Describe, if you will, the process, how you herded the cats, if you will, in order to agree on a process. That alone, I think, is noteworthy, and I think it's worthy of repeating.
Oh, I appreciate that. So what I'll say is that my desire to get involved in this was a reaction to a question that I had posed to our advanced practice provider team when I had originally arrived at Duke. And I said, what would bring the most value to your day? What can I do for you? What's sort of a pain point on a daily basis? And one of the things they said was, we need to tackle this anticoagulation, antiplatelet issue. And so I said, well, tell me more. And we looked into it more. And my gosh, were they right in terms of the amount of mental burden and emotional burden and time sink that was occurring on a daily basis because of the, to echo Bobbie's words, variation that was being introduced and lack of evidence-based sort of practice from all sides, that it was slowing down our efficiency. It was leading to less efficacy with regards to how those patients were managed, less safety. And we weren't taking advantage of working as an interdisciplinary team. And I say interdisciplinary team, meaning with our PharmDs from the hospital side, with our surgeons, with our hematology colleagues, as well as other anesthesiologists who we brought to the table. So for us, it had to do with speaking to everybody's desire to relieve what was becoming a mental and emotional burden on a daily basis that was preventing us from doing good jobs for our patients. And then, too, when we would stop and ask an outside cardiologist for their opinion, sometimes we were getting back recommendations that we truly didn't feel we could abide by. And so I stopped and I said, well, why are we asking someone's opinion that we don't necessarily want, to be quite honest? And so from that was how we brought together the team. But to be very honest, I can't take credit for any of this. Saul had brought this team together and they had been working on this long before I arrived. We just sort of got the cats back into the room and we framed this more as a systems issue around efficiency and effectiveness. And we went from there. I think the other thing that sort of catalyzed this for us was the publication of Duquette's article, The Pause Trial, and having something to really sink our teeth into and say, aha, there is evidence now that this can be protocolized and people will live, helped get everybody to the table and move past what, originally was some concern about how tailored to the patient this would need to be.
What was common at Duke was that there was often fuzziness. There was often zones of gray to figure out how to interpret these scenarios, these vignettes. And inevitably, either we or the surgeon's office would refer their question to our hematology group. And our hematology group here is A+. They're internationally renowned. They're truly, truly smart, good people. But they did not answer their phone. And so it was the problem. They just had a different sense of time urgency that we do in a perioperative domain. And so that was the impetus to really get everybody into the room. It was by the temptation, if you will, the invitation of telling our hematologists that if they help us build these protocols, we would call them less often. Their phone would ring less often. And that was the aha moment. And so that really helped sort of drive all of these sort of downstream consequences of the protocol development. Jeanna, I also think you're too modest to say that not only did you collate the morass of data out there, and I think that was evident by your lecture, beautiful lecture, in a concise, nicely, if you will, delivered protocol, but you also were smart enough to sort of shop that protocol, to socialize that protocol to key stakeholders within the institution, to give them an opportunity to beat it up, to give them an opportunity to push it back. And some of them had comments. Most of them were accepting. The idea was, we're going to give you a chance to speak to it, and then you have to hold your peace. And I think it was a tedious process, but it was one that I think ultimately ended up with us having this sort of standard of care based on the evidence and highly approved by our hematology group, who now has their phone ring less often, so long as they promise to answer it when it does ring.
I think the other part that's important that we share with the audience is this really, the part that I'm most proud of, the really cool part is that we have these quarterly QA meetings where they come back to the table and we discuss complicated cases that potentially, fell off the pathway or where we did need to call them. And we also bring up any cases where we followed or adhered to the pathway and it didn't go the way we had anticipated, so that we can continue to iterate around what do we really think is the right pathway to use and how do we refine our protocol. For those of you who know me, there is never any final product. So for me, this is the coolest part, which is the ability to come back together with our cardiologists and our hematology team and the PAS clinic and anesthesiologists and relook at this and say, hey, in the last, 3 to 4 months, what kind of cool cases came up? And let's run them through the pathway and see what happened. And when it doesn't go the way we had anticipated, we say, why not? What do you think? Should we change things?
Bobbie, in your scenario, in your system that you developed, what is the role? Do you think there is a role for a clinical coagulation pharmacist in the algorithm?
We don't personally think there is. I mean, we do have an anticoagulation clinic at Northwestern, and not dissimilar to what every other anticoagulation clinic I've ever encountered, which is true at University of Chicago and other places I've asked about, is they typically take care of their own patients. So if they already have a patient that they're following, then they're happy to engage in helping you, but they don't take on new patients. And being a tertiary care referral center, we have a fair number of patients that are coming from all over the place. And in fact, I have to tell you, when we do typically reach out, and we try to do our best to always engage the primary care doctors and the PCPs and the hematologists and cardiologists, if they have them, to ask their opinions or to look for their notes or recommendations or ask the patients if they've been given instructions already. But we often find that they haven't been given anything. And this is such a confusing body and large body of literature and really a paucity of true guidelines, out there, especially until recently. I mean, I kudos to the ACCHA to finally, after all these years, to give us some guidelines on atrial fibrillation, that they, don't feel comfortable knowing when they need to stop these drugs, whether they need to be bridged or not bridged. I also think it's been a moving target that, over time, we found out that bridging has its own issues, right? And that patients may be more highly likely to bleed, even if bridging is stopped in appropriate time, even if they're just bridged. I think just also understanding the pathophysiology of, we're talking about a couple of days that patients are off anticoagulation pre-op. So frankly, I think a bigger question becomes, is when do you reintroduce these anticoagulants? And, when is it safe to reintroduce them? And when do you maybe, in those unusual circumstances, need to recommend an IVC filter or admitting the patient for Cangrelor or something like that, which is much more complicated than simply, hey, stop your warfarin, it's 5 days or something. So, they're clinical pharmacists, right? So they're not, they can follow sort of basic guidelines if they have the guidelines. But frankly, at both of the places, especially Northwestern, the clinical pharmacists would just typically be reaching back out to the prescribing physicians and asking the hematologist what they want to do. So they were just managing it, I guess, at the tip of the point, but they weren't actually making decisions. And it's not dissimilar, I think, to, programmers for, CIED, pacemakers and ICDs, where they can technically program, they can technically prescribe the Lovenox or tell the patient when to stop it, but they can't clinically put together the plan or know the nuances of what is the risk of bleeding here? And, is the patient going to have a regional anesthetic that makes a difference? And what else is going on here? So we, if the patients are followed by our anticoagulation pharmacist, we engage them, but we have not felt the need to bring them into our clinic. Our APPs, which the bulk of our care is delivered from our prep clinic with our APPs that are overseen by anesthesiology physicians, and using very, very detailed protocols, very detailed agreed upon, guidelines that we have worked out with the different stakeholders in the hospital. Really just follow it. It's, and every once in a while there's an outlier and there's some discussion around that one particular patient.
Angela, how would you answer that question?
We, like Bobbie, don't incorporate pharmacy techs into our routine practice, and our anticoagulation clinic works exactly the same way. So it's great if they follow the patient, but like Bobbie, we get a lot of patients referred in from far away. One thing I will say that I wish I had a pharmacy tech for is to do MedRec, because at our institutions, the surgeons, and I love our surgeons dearly, but they do not do the best MedRec. So a lot of times, even the anticoagulants, we're the first, unfortunately, we may be the first person finding out that they're on an anticoagulant. Now we're trying to generate reports in Epic ahead of time to see, can we generate a report of who's on this, who's on that before they come in. But I do wish I could use a pharmacy tech to go over MedRec so that the APPs, again, getting back to practicing at the top of your license, and focus on more of these other topics. The other thing that we had a huge problem with is now that we are doing so much more day surgery is when the patients left, they didn't really have instructions about when to get restarted. So I don't know what you guys are doing, at Duke and Northwestern, but again, because we weren't involved, somebody was signing them out of the day surgery unit. There was no pre-op person, perioperative person managing it. So there were a lot of errors on that end with drugs not getting restarted. And I know there's a huge medicine literature on this, the trouble with drugs not getting restarted after surgery. But I think in the world of more and more day surgery, this is a real problem. And we're trying to work on it. But I do think what Bobbie said about how do you make sure it gets started, and the cardiologist or the hematologist will say, well, restart it when bleeding is okay. Like, what do you say to a patient that's leaving 2 hours after their surgery is over? So I do think we have to think of it on both ends. And I wonder, is there some role at the other end? But we don't. I think that's a potential problem point as well.
It's a really good segue to just talk about transitional care management in a broader context for sure, but in the narrower focus of anticoagulation and starting, if you will, the drugs that we are so careful to discontinue. Jeanna, we use clinical pharmacy techs or coagulation techs in our protocol, again, so we can decompress, if you will, the work of our hematologists that are highly desired people and may not have the time, to really address our needs as timely as we want. How's that going for us?
I'm actually very pleased. We still have work to do, and I'll touch on some of the next phases, in terms of our focus. But I'm very pleased with where we are on a couple of fronts. I'm very fortunate. We do have pharmacy techs who are stationed in our pre-op evaluation clinics. We have 2 pharmacy techs that are stationed in our main clinic and another one that covers our satellite clinic. And one of their roles, to touch on what Professor Bader was saying, is actually to make contact with the patient several days before they come to our clinic to start a MedRec so that we can know of scenarios in which we otherwise would have lost several days of time to manage when it comes to those high-risk medications. But I will clarify that when it comes to the referral and bridging of our patients who are at high thromboembolic risk, that's actually performed by a PharmD who's not physically stationed in our clinic. And she and her team do work off of clearly set protocols that were developed external to the project that we're working on now, but that were validated for use in the perioperative space. But that's how we've been working on it. And to date, we have not had them refuse somebody who is not their personal anticoagulation patient. However, they've warned us, do not advise this patient to discontinue their warfarin until we've confirmed that their Lovenox bridge has been approved by their insurance, because sometimes there can be a delay. I don't know if Saul, if you remember us going around the block on this a couple of times between when they start working on this and when the patient actually physically has the Lovenox in their hand. And so what we did at first, in my zeal to get going, was we would tell patients to stop, their warfarin on a certain day and hustle them on over. And that led to, a gap at first because I didn't realize what delays there were. But they have been gracious enough to accept patients who are external to our system. I don't know the specifics of how or why they're able to do that. In terms of phase 2 for our own initiative, you're absolutely right. It focuses on how do we restart these medications in a more evidence-based, standardized manner. I think that there is some literature to guide us, such as the PAUSE trial, for some of the most standard, straightforward cases. And I think we should revisit some of that as we bake that in. But then, like anywhere, there are cultural challenges to overcome when it comes to wait until bleeding stops, just like Dr. Bader said. So we're still working on that. And I wouldn't say that that's as shored up as our preoperative program at this point.
Saul, can I actually ask a question?
Of course you can. Well, let me ask Jeanna and Andrew if it's okay. I think we all think it's okay.
Sure.
Thank you.
We'll go with yes.
So, I have to tell you, I've just, a few years ago, I thought, there was, especially when I came into Northwestern and the hospitals were in the clinic, they were bridging so many people that it was really a burden, I think. So now I have to tell you, I frankly tell most people, the first thing you should say is just think about just stopping these drugs. I mean, we don't bridge DOACs and NOACs. We bridge very few people now who have atrial fibrillation. And we've just bridged way too many people in the past. And I think the benefits of bridging are so limited that, frankly, I think it's sort of, that's why we have not, I think, felt that we needed another additional help with this, because once we had some standard guidelines and the APPs were not having to reach out to the individual prescribing doctors constantly and ask and negotiate. And then they say, stop 24 hours. And the surgeon's like, no way am I going to operate, unless they stop for 2 weeks. And everybody had individual opinions and it was like herding cats. Once we had standardized guidelines that we went by, and most of our guidelines, at the end of the algorithm, it's just stop the drug.
Right.
So I just feel like this whole Lovenox and bridging thing is almost a thing of the past for the most part.
we're doing it, sort of having been in this area for 2 decades, we definitely are doing a lot less bridging than we used to. And I'm not sure I'm sure part of it is because of DOACs and, also fewer mechanical valves. There's just many reasons, but I do agree overall we're needing a lot less bridging. Maybe that even makes it harder because then when we do need it, we don't have a very easy system to get it going. And one of the other things we find is because so many patients come from outside Massachusetts, we don't get a nurse to teach them how to give injections. It becomes very complicated if the patient is not in your system. But I definitely agree with Bobbie, bridging is becoming less and less of an issue. But, there are still definitely times when you do need to figure out how to do it.
We trained a couple of our nurses in our preoperative clinic to just give bridging guidance for injections. Yeah, we teach them right then and there. So far, I don't think anyone's really run into any challenges. And we've had an occasional patient with a Lovenox and being able to get approval. But again, I'm not even sure that almost any patient needs bridging except somebody who has a very recent VTE, who the first question you should be asking yourself is, why are we doing surgery, right? So the patient should probably not be doing surgery. And then, the patients who have stents that, need antiplatelets. So Lovenox is not an issue there. And you're going to be admitting that patient. And usually it's more of a problem of getting them admitted and getting their insurance to pay for, the more expensive IV antiplatelet drugs. Or the rare patient with some mechanical heart valve that needs bridging. And most of the time we have found that because it's a mechanical heart valve, that the insurance companies are absolutely approving those pretty readily. So just saying this because I want those people who are listening who maybe think that, oh God, this is just such a challenging problem. This is such a big deal or so impossible to deal with. It's really not that bad, I don't think. Not that challenging.
I agree.
A lot of it's coming up with the guidelines. We're happy to share our guidelines with you. If anybody wants to, you can email me. I can send them out. They're as good as the people who wrote them, but
they're excellent.
They're pretty good.
But
some literature.
Yeah, I just want to make one comment. I can't help myself.
I do have to make one comment. The other clinical scenario that we run into with regards to patients on warfarin are patients who cannot afford DOACs or whose insurance do not cover them. So I don't know if that's a regional thing or. But I would be remiss in not including that in part of our discussion of patients who still are on warfarin who otherwise would be on a DOAC.
I think one of the biggest problems I see is patients who, and I know that's not the topic of this particular session, is bridging comes into the conversation when you're talking about how soon to do surgery after a recent DVT or PE. And we seem to be getting in these discussions all the time. And how do you do after a stroke, after that's where, and I totally agree with you, Bobbie, but I actually think I might have emailed you recently about this saying there is no evidence. So we're arguing about when we should do the surgery. And then we're arguing about, well, if we're going to do it, when should we bridge? But the problem, those are, I would say, a lot of the cases where this discussion happens, at least where in my institution.
Don't forget, of course, you can find the other part to this piece if you check out the show notes.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.